I'm really delighted to introduce again Robert Francis QC, who, as all of you know, has been spending the last few years of his life looking into the Mid-Staffordshire scandal in healthcare in the UK, and he's here to give us what he sees as his lessons for healthcare. Thank you very much, Robert.
Well, thank you very much, Fiona, for that. First, it is obviously an honour to speak at this distinguished gathering. It's also somewhat formidable. Us mere trial attorneys, as the Americans would call us, or barristers in this country, are more used to speaking to a maximum of 12 people and more comfortably a maximum of 3 rather irritable judges. And instead I have this very large audience, but I will do my best. Now, those of you who come from the healthcare system in this country may by now be getting slightly tired of hearing about me, or in many cases from me, as I have in the last 2 months been speaking about my inquiries quite considerably, and I hope that they will forgive me if I spend some time filling in those who are less familiar with the problems that we have been facing. I was asked to chair an inquiry into how it was that a hospital delivered appalling care to a very large number of patients over a number of years. And the first inquiry I was asked to do involved the hospital itself, and then a second, more public inquiry looked into why it was that the National Health Service as a system had failed to detect that things were so bad there. But before we quite get to that, may I start with a little bit of a history lesson. Florence Nightingale, in her seminal book on how to build a hospital, said that it may seem a strange principle to enunciate as the very first requirement of a hospital, that it should do no harm, the sick no harm. It seems unhappily strange to me that 150 years later I found it necessary to quote that in a report concerning the care of a hospital in the 21st century. But before we leave that slide, can I just point out 2 things. Firstly, Florence Nightingale identified a principle, and secondly, she backed it up with evidence. She analysed mortality statistics, such as there were at the time, to produce the conclusion that it was necessary to enunciate that principle. Now, she also wrote, of course, a famous book on nursing, and another maxim came out of that, which was that what can't be cured must be endured, is the very worst and most dangerous maxim for a nurse which was ever made. Patience and resignation in her are but other words for carelessness or indifference, contemptible if in regard to herself, culpable if in regard to her sick. And while that is clearly as relevant today in relation to nursing as it was then, I venture to suggest that it's a maxim that could well be borne in mind by all those who have anything to do with healthcare. Certainly my inquiries uncovered an attitude which tolerated poor care, often on the basis that it would be too difficult to do anything about it, even more often on the basis that, well, the same sort of care was being delivered elsewhere, therefore, in some way or another, that made the lapse in standards acceptable. And I do think that if we are to have a health service which does not cause harm to people, we have to get away from an attitude of toleration of things that, in fact, we just should not accept. Just before we leave Florence Nightingale, the contents list of her first book on hospitals contained all those items. And another sad commentary would be this, that I could probably have written a critical chapter in relation to virtually all those subjects about the care being delivered in Stafford. So don't let anyone tell you that old principles are no longer relevant. So, what was I about? Well, at the time of my first inquiry into this hospital in July 2009, there had already been 5 inquiries into Mid-Staffordshire. The Healthcare Commission had written a highly damning report which was published in March 2009, which caused an uproar. The Department of Health, locally, an independent case note review was commissioned, which eventually found that some 65% of the case notes they reviewed, self-selected from those who had complained, contained aspects of care about which there should be serious concern. A report was commissioned into the efficacy of the Accident and Emergency Department, which was very critical, as was a further report on the commissioning of the services in that hospital. And you might well reasonably ask, why against that background was it necessary to hold an inquiry staffed by a barrister, which is what happened in July 2009. And the reason was this, that it wasn't felt at that point that enough voice had been given to those who had actually suffered in this hospital, and what they had to say had neither been listened to nor, most importantly, learnt from. And my principal task was to do that listening. So we heard 133 witnesses through oral evidence. Over 900 members of the public contacted us. And unfortunately, of those 900, 690 of them had only bad things to say. 275 had some positive comment. And the report, which if you are in the healthcare system in this country, or dare I say it elsewhere, is worth reading, if only for its volume 2, because that contains a summary of every single story we were told. And they make sobering reading, and each of them is a case study from which a lesson could possibly be drawn. I, however, was puzzled when this report came out to be told continuously that it had had a seminal impact on the attitudes of people in our health service. And against the background of all these other inquiries, I asked myself, why was that the case? And the only answer could possibly be that people who read this report were confronted, perhaps for the first time, with the enormity of what had gone wrong. However, such is the penalty of running a public inquiry, that punishment is you get another one to do. And the second was into the system as a whole. And this was a public inquiry, which in this country is quite an elaborate affair. The result of that was that we had delivered to us over 1 million, it was near 1.2 million pages of documentation, of which I should think 30% were internal emails of the Department of Health and other bodies. And if there's one lesson to be learnt, ladies and gentlemen, it is never put in an email what you do not want to be read out in public. And that probably goes for tweets as well, by the way. We heard 250 witnesses, and all those figures are up there on the screen. And you might well ask, well, what is the advantage of this sort of procedure? What did it tell us that we didn't know before? One advantage for the public is that there is a transparency. They get to hear what people they hold responsible for failings actually say they did, and perhaps more importantly, what they didn't do, and what they propose to do about it now. And that is in itself a form of holding people to account. It also allows the public at large to participate in a debate about what should happen in the future in a way that it can't happen before. But it's not worth the money, ladies and gentlemen, even though my inquiry, as you can see, is commendably cheaper than some. It is not worth the money unless that it results in change, and the history of public inquiry is unhappy. And many sink into the dust, and their recommendations are not implemented, and the same scandals happen again. And so that's the one sobering message to take home with you, or one of them. Can I then turn to the people who are really important, who were the people who suffered? The picture you see on your screen, on the screen, is of a group called Cure the NHS. These are the relatives, mainly, of patients who mainly have unhappily died, and they wanted answers to the questions of why their relatives had suffered appalling care, and you see the pictures on the wall behind them. They were led by this redoubtable lady, and still are, Julie Bailey, whose mother died after an appalling experience in this hospital. And she was and remains determined not to rest until changes occur which will stop this happening again. She and her colleagues are what are offensively called ordinary people. There's nothing ordinary about these people at all. They innocently trusted their loved ones to a hospital expecting good care and found themselves in some cases in something approaching a war zone, and they have set about, against institutional resistance, to do something about it. Julie Bailey, who runs a cafe in Stafford, and that's what she does for a living, and it's a cafe, I should say, which is now visited by more Prime Ministers, Secretaries of State for Health than any other cafe in history, has to devote her life to this, and at a cost. And I don't mean just the cost of to her business or indeed personally in terms of media appearances and so on, but she is spat at in the street by people who think that she has traduced their local hospital. Her mother's grave has been desecrated by members of her community, and she then receives emails gloating about that. And it is a terrible fact that those who put forward the truth, the uncomfortable truth, do often have to pay a terrible price for it. And therefore we should always pay huge admiration to people like this. And when anyone tells you they are being difficult, quite often there is a very good reason why they are. Now, turning now to some of the stories which I had to hear, the lessons that can be learnt from listening to those stories. We have here an account of a relative who couldn't find a nurse to help her relative because she needed help to go to the toilet, so she did what she could to help herself. When she came back and talked about this, no one wrote it down. And it seemed to me that this sort of story, which you see on the screen, it tells you two things. Where was the care that was necessary? But also, what's happening to the record-keeping system? Isn't it important that these sort of things are recorded so that proper care can be given and indeed that lessons can be learned? Here is an instance, trivial you might think in itself, but really important to the individual, from which you can learn that something seriously wrong is happening in that ward. But that lady or that patient had someone to speak for them. We need also to think about those who have no one to speak for them. This is the evidence of a family who were asked to help feed their relative. Nothing wrong with that if the relatives are prepared to help. But the very important point this family were making was, well, what about those who didn't have families visiting? It's a sad fact that many of the elderly in our hospitals, for all sorts of reasons, don't have anyone visiting them and don't have relatives who want to come and care for them. Who speaks to them? Who is finding out whether those people are getting proper care or not? Then there's this sort of information. This was a report produced as a result of a whistleblowing nurse, a brave lady, who complained about the care that was being provided to patients in the ward where she worked. An external report was commissioned by the hospital, and it was highly critical. It said that there were poor governance arrangements, but most importantly, it said she discovered a lack of commitment at the highest level of the trust to tackle these problems. Now, this report was handed, a seminal report showing systemic failure in a hospital. It was handed to the interim chief executive. That tells a story in itself. The previous chief executive had been, I quote, moved on, unquote. It was shared with the chair of the board, but not the board itself. Why? You might think this would be an automatic matter to go to a board. Because this board only concerned itself with what it regarded as strategic matters, in inverted commas, not operational. And a report like this is operational. So it was never seen by the board. Then I come to a truly horrific story. We got there about 10 o'clock and I could not believe my eyes. The door was wide open. There were people walking past. My mum was in bed with the cot sides up and she hadn't got a stitch of clothing on. I mean, she'd have been horrified. She was completely naked. And if I said covered in feces, she was. It was everywhere. It was in her hair, her eyes, her nails, her hands, and on all the cot sides. So she had obviously been trying to lift herself up or move about because the bed was covered and it was literally everywhere and it was dried. It would have been there a long time. It wasn't new. So many people must have walked past and seen her. Why didn't someone go into her? Do you need to know more about a hospital in trouble than that particular story, which would be buried, if it was a complaint, as a statistic? And in our system, at the time at least, all such complaints would have been categorized as all aspects of clinical care. Then you get this. This is another report prepared by the in-house trust's lawyer into the death of a patient in April 2007, a date which is significant for reasons I'll come back to. This was an insulin-dependent diabetic who was admitted with a broken hip. The A&E department were told she was an insulin-dependent diabetic. A doctor wrote up her for insulin and said she should be seen by a dietitian. She was moved through several wards, and 11 days later she died because she hadn't been given insulin. And she hadn't, in fact, been seen by a dietitian, and for good measure she'd also contracted Clostridium difficile as well. So it was declared a serious incident, and this report was produced, and the solicitor concluded that there were all these systemic failings in his organisation. And not surprisingly, his conclusion was that this wasn't an isolated case, and it was likely to recur. This report was not seen by the board either. The serious untoward incident was reported to the performance manager, the Strategic Health Authority, but no follow-up, but they didn't get this report, and there was no follow-up by them until after my inquiry had started in, I think, 2010. But what else would you need to know about a hospital than a case like that? Well, you might have wanted to know about these figures. Professor Jarman, who created them, is in the audience. But the same month as that lady died, the Daily Telegraph published the HSMR for the country, all the hospitals, and this trust was had the fourth highest unexpected mortality of any trust in the country. And what was the reaction to that? Well, the reaction was, those figures can't possibly be correct. It must be down to coding. The coding in our hospital is inaccurate. Why that should reassure anyone that the place was properly run, I don't know. But the effort that was then put into challenging the reliability or the significance of such statistics distracted everyone from the task of actually asking themselves, is there anything we ought to be worried about in relation to the care? Should we not be looking at the actual care given to patients in the diagnostic groups where where mortality was high? Little, if any, effort was made in that direction. But it wasn't just the care of the elderly, really, who were a cause for concern. The Royal College of Surgeons was asked to do a review of the surgical division in October 2007. And these are some of the findings that they made in a private report written for the Trust. And they said the department is dysfunctional and has no effective leadership. There were no agreed protocols for bowel preparation in colorectal surgery, and the result of that was that the theatre staff didn't know what to do between one surgeon and another, depending upon which one turned up to do particular surgery. You might think that was unsafe, and indeed, when they came back in 2009, nothing much having changed, they said that the department was dangerous, but it was dangerous then. But that report was not seen, as I understand it, by the board as such. It was because it contained personnel matters. It wasn't seen by Monitor, who were later considering authorising, and did authorise this as a foundation trust. So the information was there. Then there was the trainees. This were extracts from a survey filled in by a senior trainee in the Accident and Emergency Department. And as you can see, he wouldn't recommend the post to his friends. Categorically no, he said. And there was a whole litany of things that he thought were going wrong there. Trainees, ladies and gentlemen, are eyes and ears untainted by familiarisation with the unacceptable. And they're an underused resource, I believe, in our hospitals for finding out what is going wrong. They haven't been there very long. They're often not going to stay there very long. And if you ask them, they will tell you. But don't do what one person privately told me happened. And this was, in fact, a graduate management trainee who was at a social event asked by the chair of a trust whether there was anything she'd seen which worried her. And she said yes there was, and she explained what it was. And he said he was very grateful. But the next day she was called in by the chief executive, to be seen by the chief executive, who said to her, "Don't you ever do that again." That was not in Stafford, that was somewhere else. So, although many people said, both inquiries and in public, they couldn't understand how it was that these problems at Stafford were not discovered, because no one raised them. The information was actually there if you looked for it. And I haven't been through all those issues, but some of them were there. But of course, not all information is shared. And why is that? Well, the first point is fear. Patients are afraid of making a fuss, because they're afraid of the repercussions. They're afraid that if they complain, the care they get will actually get worse, not better. Now, one would hope that is not justified in most cases, but if the fear is there, then there is a barrier to people talking to you about what they're worried about. People are intimidated not necessarily just by threatening nurses, although that can be a problem. The real problem is that they are in unfamiliar surroundings. They aren't familiar with what is right, what is wrong. They are afraid for that reason to speak up. Then you do get, I'm afraid, the ill-judged comment, "Don't moan," will result in some people not moaning. And finally, there is that, dare I say, British rather than American habit of not wishing to be a nuisance and not wishing to make a fuss. You know, when you go to the restaurant and you have this overcooked steak, a vinegary glass of wine, and you're asked if you look how the meal was, and you say it's fine, the same attitude has much more serious consequences in a hospital. Now, what effect does all this have on the staff, who we may think should raise concerns? Well, the first is we have to consider the stress of working in an environment where things are not being done properly. This nurse was a brave nurse who in fact was a whistleblower, but her feelings were that she felt ashamed at working where she did, because she felt she'd done her best, but she went home and felt really upset because you can't say you've done anything to help. You feel like you've not. Although you've answered buzzers, you've provided medical care, but it's never seemed enough, and so on. And that results in a dissociation. This was the same doctor who filled in the survey form I mentioned before. And he said that the nurses were so under-resourced, they were working extra hours and were desperately moving from place to place. And he said this: if you're in that environment for long enough, what happens is you become immune to the sound of pain. You either become immune to the sound of pain or you walk away. You cannot feel people's pain. You cannot continue to want to do the best you possibly can when the system says no to you. You can't do the best you can. But when people do speak up, I've mentioned Julie Bailey, this is what happened to that whistleblowing nurse when she raised concerns that she was being asked to fabricate discharge times in accident and emergency in order to make it appear that the trust was fulfilling its targets in relation to accident and emergency waiting times. And she was receiving physical threats from the friends of those that she held responsible for this practice, and felt she was getting no support, and she felt she needed her family to meet her in the car park in order to get her home safely. Now, whether anyone would have exercise those threats or whether they wouldn't isn't the point. The fear is there. And for every single person who says this, particularly if they say it in public, there are going to be 10, 20 people who say, well, if that's what's going to happen, I'm not going to speak up. So we do need a culture, and this is nothing the law, I fear, can do anything about, but everything that leadership can do something about. We need to banish the fear that comes with speaking up about things that worry staff about professional behaviour and service. The alternative to that brave nurse is, of course, this is evidence given by a senior consultant, so senior he was for a time chairman of the consultants' staff committee. And he was saying, he being a physician, was perhaps freer in his conversation about surgeons, but he said that they carried on not raising their concerns because they had no other beds, they had to use what they were provided with. And we'll have to make mend and do, he said, which is the Stafford way. And I fear the way perhaps in many other places as well. Even more candid, however, was the evidence of a senior consultant who was about to retire. And he told me that he could have been more forceful in his statements of concern, but he'd got to the stage where I was less involved and was heading to retirement. I didn't have a managerial role, and therefore I didn't see myself as someone who needed to get involved. Perhaps my conscience may have maybe raised concerns if I'd been in a management role, but I took the path of least resistance. In addition, most of my patients were day cases, and they had less impact on them, so that was all right. There was also veiled threats at the time that I shouldn't rock the boat at my stage in life. For example, I needed discretionary points or to be put forward for clinical excellence awards. Highly candid and probably much more widespread as the reality than one might imagine. And leadership, I suggest, has to tackle and recognise those factors which stop people raising and pursuing concerns to protect patients. So why weren't all these things discovered? Well, there's a list of them, and I'm not going to go through all of those now. But the principal one must be not listening to patients, and I would suggest the next principal one is barriers to sharing of information. But in the middle is one which is all-pervasive, which is in systems which often have lots of people who are responsible for the same activity. It's very easy to think that it's someone else's responsibility, therefore someone else will be doing something about the problem, therefore I need to do nothing. And we need to inculcate in our staff, do we not, a feeling that it's all our responsibility and it doesn't matter whether someone else is doing it. If they're not, then we have to do something. But the NHS, it was also clear, had this about it, that people were concentrating on doing the systems business, not that of the patients. There's a priority on personal survival. I heard that it is still, I think, the case that the average tenure in office of a chief executive in an NHS trust is less than 2 years. And no one can be an effective leader if everyone around them thinks, are they going to be here tomorrow? There is the balance about news. I'm just picking points at random out of this. It's allowing good news, the proper congratulation that is should be attracted by good practice and achievement. But somehow that's allowed to excuse the existence of bad. So if you're doing good things, then it's not so worrying that bad things are happening. It doesn't feel like that if you're the patient at the wrong end of the bad cab. And it's also about the weight given to information. It is much easier to believe congratulations and compliments and affirmation by a regulator, for instance, that you've got 3 stars, than it is to think of the consequences of HSMR information, for instance, being right. Action plans. I plead to all my audiences, can we please abolish the phrase? In the NHS, the answer to everything is an action plan, but unfortunately they are often neither plans in the proper sense of the word, nor do they involve action. It is thought to be the solution in itself. But finally, lack of candour, openness and transparency. This, I believe, is what will motivate change. I will pass over all those. Those are more systemic matters which will be quite of local interest. So I got to make some recommendations, and I made 290 recommendations. when I started off the process, some kind person said to me, no, a good inquiry produces 10. Of course, that may be right. But if you identify, as I think I did, that what was wrong was an institutional and cultural behaviour, not just in a ward, not just in a hospital, but actually throughout a system producing something which is unsafe, then you do need, if you're not going to completely reorganise it, and even if then, where are you? You need to actually inculcate something into all sorts of nooks and crannies, and that's what I tried to suggest. I have no idea as we sit here which of these are going to be put into place, but there are some themes, and those seem to me are the themes behind my recommendations, and those, if you like, are the aims that, whatever happens, we should be striving to achieve. As we sit here, the other thing the NHS is very good at is waiting for someone else to tell them what to do. And one of the messages I've been giving since my report came out is that while a lot of detailed work needs to be done, and Professor Berwick is doing some of it, there is an awful lot that could be done right now by individuals and by organisations. We can define quite easily the common value. The common value we need is put the patients first. But let's do that. And let's identify what are the fundamental standards, breach of which should not be tolerated. We need individuals who are prepared to tell employers about the harm and risk that is done to patients, about concerns they have about fundamental standards or the ability to deliver service. We need professionals who offer leadership, who are responsible for the patient and not just the problem, and who create the means by which transparent performance measurement can be undertaken. And they should stop saying, it's too difficult, I can't do it. None of us like to be compared with others, particularly if we're not that confident in what the results might be. But it is necessary, it seems to me, to prove that what we are doing is effective. So the hospital itself can do all sorts of things. It can welcome concerns and complaints. It can make sure they know what services patients actually receive, as opposed to what they think they receive. They can investigate safety issues and concerns rigorously, not just assume that there must be an innocent explanation for what has occurred. But they must tell the truth to patients, the regulators, the public. I'm afraid the Stafford board did not tell the truth to patients, regulators, or the public. They must have balanced information. They must be open about concerns as much as they are about achievements. They must do all these things. They must involve the staff in what is necessary to do to change. It is the staff that know what's going wrong. It is the staff that know how to put that right. Listen to them. It is really important to listen to the staff as well as the patients. Fundamental standards, I propose that we should have them and that some of them should be backed up by criminal sanction. It does seem to me that there are some things that, at the moment, we have 355 pages of guidance on outcomes and measures by which the Care Quality Commission will measure the performance of a hospital. And yet, I would defy any nurse, you to find a nurse on a ward, or still less a patient, who would know, looking around the ward, whether what was happening there was in compliance with those standards or not. Do we not need a list of quite simple things which must be provided, and if they're not, then serious consequences might follow? The slide I had of the lady in the faeces-stained bed, there really isn't an excuse for that, and we need to define some standards that actually say that is intolerable. But we do need a system behind all this, and this is where obviously it gets more difficult. I think we need fundamental standards. We need proper guidance as to how to comply with those. We need to encourage the front line to report their concerns, and we need to stop services which are persistently not complying with what is necessary, and penalise avoidable and serious non-compliance. We need an honest system, so we need staff to tell the employers what's gone wrong. We need the organisation to tell the patients about that. And if a patient is deceived, dishonestly and deliberately, of course, why should there not be some sanction about that? And if others are prevented from providing this information, should there not be a penalty for that? Is it appropriate to allow victimisation, as that nurse suggested happened to her? And do we not need transparency about complaints and concerns so that not only the trust hospital knows about those, but those who commission the services know about it, so that regulators know about it? And I don't just mean numbers, those stories, which seem to me as powerful as sometimes as the numbers. Well, finally, can I just leave you with this thought? This gentleman is the partner of the lady, the insulin-dependent diabetic that I mentioned earlier. And I think he speaks for all those who suffered at Stafford when he says that he came to my inquiry, that he was not there for himself. I'm here for Jill and the rest of the dead. I'm not being sanctimonious. I could walk away at any time, but I'm not going to. When they took Jill away from me, they took away my contentment. I don't want anyone else to suffer that. Bereavement comes to us all, but it's how it comes to you that's important. Thank you.
Robert, thank you very much indeed. We've got some Twitter questions, and I'm just going to invite Harriet and Joseph up to, though they are our information DJs, they'll ask the questions that I wouldn't dare to ask. But while they're just getting there, let me ask you one. I mean, it's in a very extreme and dreadful story, which you've had to hear repeatedly over a period of time. I just wondered about the business of moral offset, which you talked about, where people are doing good things in healthcare, and then they kind of think, well, therefore I can get away with these bad things. Is that something you felt you witnessed quite a lot, or was that?
Yes, I did. I think there are various aspects to this. One is the looking at the say statistics, and I'm taking examples at random. The patient satisfaction survey, which might tell you that 65% of the patients would recommend the hospital to their family, for instance. And that is thought to be great news because last year's figure was 60%. And it's an improvement. Well, it may be an improvement. It is still absolutely shocking because you've still got, get my arithmetic right, Professor Jarman, 35% who would not say that. And then you convert that into numbers. And you think the number of people who've not had care. And then you think of their families who are all going to think the same thing. That's an absolutely shocking figure. And the other part of it is the fact that you say, as this trust did, we got foundation trust status. We are now in the Premier League, is how the board described itself in a press statement. The chief executive continued to say that in a congratulatory newsletter some months later. It was the 150th anniversary of the hospital. Even though at that time the Healthcare Commission were investigating the hospital, and even though he, as a chief executive, had received 2 letters saying patients were at risk in A&E and various other places. And one just does not offset the other in any shape or form. And yet, we all do this. You know, we listen to the compliments and the congratulations and the achievements, and somehow that makes us feel comfortable allows us to forget other things. And I'm afraid the job of a board or the job of an individual professional is the whole time to question what it is you're doing and whether you're actually succeeding for each and every patient you have.
Thank you. Harriet and Joseph, tell us what the Twitter sphere wants to ask.
The first question, what was the single biggest failure?
Where do I start? Well, I think the biggest failure has to be around, I'm sorry, I'm going to take 2. There are 2 failures. One is around the board and its operation. And I don't want to single out individuals in any way or other, but there was something about a rigid adherence to a concept of strategy and operational matters which didn't make sense to me, and I don't think it makes sense against this background at all. And it led to a divorce of the board from the reality of what was happening in certain parts of the hospital. So that was a really big failing. But there is an even bigger failing, I think, which is around the professionals in the hospital. I believe that the professionals did not do what they should have done. They must have known. There must have been lots of professionals who knew that things were bad, and we've seen some of the reactions to that. And there's then the interaction between the two. One feeds off the other. I do raise a concern, nobody listens, so I'll give up, which is unprofessional, but it becomes a cycle. So those are my two big failures.
Thanks.
Sorry, one more question that was asked from those viewing me today on the live stream was, what defence was offered by the board and those providing frontline care for the care that they provided?
Well, part of what the problem was lack of insight, and I found, and there were those, and they're obviously still represented in the public if the behaviour I've mentioned is reflective of this. There were those on the board that felt that all these findings and criticisms were unfair. Yes, of course, there'd been pockets of unfortunate practice, but the whole thing's been exaggerated. That people, it was said, weren't being fed and watered, and there was a lot of exaggeration, and you wouldn't necessarily believe a patient's complaint. You shouldn't do that. And whereas my attitude, I was criticised by witnesses that say, well, you've accepted what the patients have said, and that's, of course, your prerogative. But, well, if you've got that attitude, then you're not actually going to tackle the problem. And I believe that you can take this to extremes, of course, but a board should be concerned about any single one of those stories and believe whatever's there needs to be corrected, and corrected now, not in an action plan that's not going to ever be implemented, or if it is, in 2 years' time.
And as in terms of accountability, people listening to this might think, well, why aren't the board all named and shamed or sacked and pilloried in various different ways? Why not?
Well, the board of the trust is no longer the board. The chair is not the chair. The chief executive is not the chief executive. So they've got what they did or didn't do is laid out in the report, 2 reports now, and they're named in it. So that's as far as an inquiry can go. There is, however, undoubtedly a lack of accountability in a formal sense within the National Health Service for people in leadership positions, by which I mean board directors. And there is not a level playing field. If a medically qualified medical director, for instance, can be hauled up in front of the General Medical Council for his inaction or failures as a medical director, the chief executive, who comes from a background of, management of the NHS, has no such constraint. And I have recommended there should be accountability through a disqualification procedure, and I still believe that to be the appropriate response. That the public, I think, demand an accountability which just isn't there at the moment.
Thank you, Harriet.
Okay, final question. If we looked at other NHS trusts, would the same situation, issues, problems be found?
Well, as chairman of a public inquiry, I have to go on the evidence which I was asked to look at, and I was asked to look at the problems of one trust. But I think what I can say, and I've said this before, is that what I found about the system as a whole, the regulatory system, the oversight and so on, is that it has such holes in it that you can't, there's no way of knowing at the moment whether there's another Stafford out there. And I could add this anecdotally, that I received continuously through the inquiry requests from distressed members of the public. Could I please look into an alleged scandal in such a trust or another, which I couldn't do because it's not within my terms of reference. So I think it's right to say there are a lot of people out there who believe that there are other Staffords. I think more credibly, there are certainly pockets in individual trusts which might look like Stafford. And what we need to remember is that not everything in Stafford was bad. There was some really good practice that went on in some parts of it. But that's the danger. You get silos in hospitals and trusts. And I think there must be a fair amount of that going on around the NHS.
Harriet and Joseph, thank you very much. On to Twitter. So, Robert, moving on to what happens now. The government has come up with its initial response to your recommendations, to your report, and they've suggested they might do some of the things you've recommended. They've also suggested they'll do some things that you haven't recommended specifically. I wondered if you could just give us a sense of how you see this initial response. How optimistic does it make you feel? Well, I recognised when writing the report that
two things. Firstly, the solution, there is no single solution that's going to change things overnight. So any change is going to take some time. But the other recognition is that that's what's happened before, and other reports have been produced. The Bristol Inquiry report would be an example where the recommendations weren't put into place and the whole thing slowly disappeared into the dust. And one of the reasons, and this isn't me for going and preaching the gospel, one of the reasons I decided not to do what other very wise chairmen of inquirers have done, which is to go away on a long holiday to a nice sunny country, but to actually stay around for a bit and talk about it, is to actually promote and encourage the sorts of discussions we're having here. And I've recommended that there should be a regular review, not by me because I'm not the expert, but a regular review by the Health Select Committee and an accountability by all trusts telling us in the public what is happening. And I think that's necessary. But the specific answer to your question is that there are some things which have been accepted. That's fine. The government has said it, in effect, accepts the principles about most of the other things there. And some points are difficult and challenging, and therefore it will take time to think about them. So I'm prepared to say at the moment it's too early to say. But the longer it goes on without action, the more worried I will get. And that's why I'm saying at the moment it's important that everyone who has a leadership position in a trust, and that includes all the professionals, are thinking about what they personally or collectively can do now, because a lot of this could be done now and without government intervention. And I think the health service needs to get away from a culture of waiting to be told what to do.
One thing that I think they haven't explicitly taken on yet is your recommendation of some degree of minimum staffing for nursing in hospitals. And as I'm sure people listening and those who know of this already will sense the feeling of the pressure under which the nurses were acting within that hospital.
Yeah. Well, as you know, I not only had formal evidence sessions of the inquiry, I held a series of seminars. So I took into account the debates I heard in those. And I decided it was not to recommend, as it were, a fixed standard, as a fundamental standard, if you like, of saying there must be X nurses per X number of Y number of patients, because I think the needs will change and there may be different methods of doing things. What I did think is necessary is for there to be evidence-based guidance on a activity-centred basis. So each specialty, each type of patient, it should be known how much nursing care was likely to deliver proper care, and for that to be promulgated. And if that wasn't then being followed in a particular place, questions could be asked about how such a trust could be delivering proper care without it. And so what I'm suggesting is that there should be that sort of guidance, and which allows a greater degree of flexibility. But I do think that, and I think that's going to be more effective than an overall rather blunt instrument, which I don't think will actually fit the bill. And also what would happen then is everyone would then just use that number of nurses, even if more were needed.
Another aspect which again may surprise people who don't know the system which was operating there is the business of patients not really knowing quite who their doctor was, or no one doctor feeling that they had accountability for that patient. And you recommend that that should be the case. Do you think that is likely to happen, and what might prevent it from becoming the reality?
Well, I think it's essential, and going back to the question about how prevalent things are, I can tell you I've been now to a lot of hospitals to visit patients as much as being chair of an inquiry, and no one ever seems to know who their doctor is unless it's except in very exceptional cases, or who their nurse is. And I think it's essential for a feeling of responsibility that on a day-by-day basis the patient knows who is the person in overall charge of the case. And I don't believe that to be inconsistent with a teamwork approach to care. But if you take the care of the elderly, for instance, they have very complicated care needs which need coordination. And someone needs professional responsibility at any given moment for coordinating that and for being the person who knows the information and to whom patients and relatives can go. Is it difficult? Possibly. And I know that there's an issue that physicians have, that there are no longer general physicians who will perhaps be the sort of people who would normally do that. But I don't really care who it is, as long as there's somebody, it doesn't have to be the person who is personally delivering the care, but there does need to be someone who has the responsibility for making sure it's being delivered.
The government has announced an additional hospital inspection and hospital rating system as one of their kind of immediate initial responses, and that has a degree of logic behind it. People are worried that it will just be yet another layer of activity, and how will it work? Can you give us your sense of...
Well, the rating.
The hospital inspectors and rating system, yes.
Well, I think there are two questions there. One is about methods of inspection, and it is right to say that the only regulatory technique that exposed Mid-Staffordshire as being the big problem it was a rigorous inspection undertaken by trained professionals who understood the business of a hospital, and doing a very comprehensive long-term investigation. When the Care Quality Commission came in, they replaced that team and that method of inspection with generic inspection by teams of people who had some training in inspection but didn't necessarily have any expertise in hospitals. And that seemed to me wrong, and I believe that the current regime at the Care Quality Commission is going to change that. So I'm fully in favour of that. As far as the Ofsted-style rating is concerned, that wasn't one of my recommendations. It isn't necessarily inconsistent with what I see, but I was interested to read the Nuffield Trust report, which the government commissioned, which points out the dangers of an overarching rating disguising poor practice in different places. So I do believe that any overall rating should have built into it, as it were, a disqualification from any form of favourable rating if there's a breach of fundamental standards found within the trust.
A lot of the conversations we're already having today are about the need to listen to patients, and we have here an extreme example, really, of failure to listen to patients, failure to believe what was being said by their relatives. Do you feel that we are now in a better place where the system's being set up and the scandal that we've heard about will change the way in which we listen and believe patient stories?
I think I've seen evidence that there has been a change of attitude and a change of behaviour in a very widespread range of people who lead trusts, and for instance many more boards than used to be the case do listen to patient stories personally and get the impact from that. And I think there's more recognition of the need for leaders to be out and about and listening to frontline staff and so on. Whether all that will survive the undoubted pressures that exist, of course, is the real challenge. And I do believe that we need to ensure that the interests of the patient are always at the forefront of everyone's minds. And that's not something you can do just by saying it once and signing a book and disappearing. You've actually got to get people to remind themselves of that on a daily basis. And I think that's one of the important things. But the other point to take away, I think, is that a lot of what needs to be done needn't cost money. And there's this feeling that you can't provide. Frankly, if you can't keep someone clean in a bed, like that 96-year-old lady wasn't, what are you doing providing a service at all? And I do think we need an honest conversation, if money be the problem, about what actual extent of service we can provide. Because if you can't provide a service where the fundamental standards are right, then you shouldn't be providing it at all.
And finally, to the people here and listening on in other parts of the world, what would be your message to present and future healthcare leaders from what you've learnt? One or two things they could go away and do tomorrow.
One or two things they go away and do tomorrow. Make sure that you have information about what your staff are doing, which are a fair reflection of their effectiveness, which you share not only with them but with the patients and the public, and you're not scared to do that. For point one. Point two is, whatever the stresses and strains, do listen to patients and their concerns, and do listen to the staff and their concerns, and bring both together to work out what it is that needs to be done to make the relevant changes. If you do those things, you don't need a regulator, and you don't need oversight, and you'll run a good hospital.
Robert Francis, thank you very much indeed.